Hi, today I'm going to talk about oral hypoglycemics. In our previous video, we talked about diabetes and we talked about the ominous octet, the pathophysiological defects that drive the disease diabetes mellitus. But today we're going to dive into a facet of the management of diabetes. We need to appreciate first and foremost that management of diabetes mellitus is multidisciplinary, and there are many things that have to be done, including managing the comorbidities, mitigating the risk factors, lifestyle modifications, and pharmacotherapy, or the use of drugs, is just one tier of management of diabetes. But let's talk a bit about that tier called pharmacotherapy or use of drugs. There are a number of drugs that can be used in management of patients with diabetes mellitus, including insulin, and there are different types of insulin, but that will be a topic for another day. We also have what we call oral hypoglycemics or glucose lowering drugs, and these form a key component of drug use in diabetes. So here we have the different classes of the oral hypoglycemics or glucose lowering drugs, including alpha glucosidase inhibitors, biguanides, sulfonyl ureas, sodium and glucose cotransporter 2 inhibitors, thiazolidinediones, which are also called glitazones. Then we have meglitinides, which are also called the glinides. And then we have this class called incretin modulators, and it is divided into what we call the DPP4 inhibitors or the dipeptidyl peptidase 4 inhibitors, and then the glucagon-like peptide 1 receptor agonists. So I'm going to talk about each of these classes briefly so that we can appreciate these drugs called oral hypoglycemics. Let us start with the alpha glucosidase inhibitors. So these drugs work in the gastrointestinal tract, and like the name says, they inhibit or they antagonize an enzyme called alpha glucosidase. This is an enzyme that is involved in the digestion or the breakdown of carbohydrates into simpler forms that can be absorbed into our bloodstream. So when this enzyme is inhibited, it means that the digestion or the breakdown of carbohydrates is slower, and therefore we have less glucose being reabsorbed into the bloodstream. And so that's how those drugs work. One of the examples that we have there is a drug called acarbose. Number 2 is what we call the biguanides, like I already mentioned. And a typical example of these drugs is a common one called metformin. These biguanides work by inhibiting an enzyme called glucose 6-phosphatase. This is a key enzyme that is involved in what we call gluconeogenesis, making glucose from other sources, from other substances within the body. And so by doing that, we reduce on the amount of the glucose that is made from the liver and shunted out into blood. So these drugs reduce what we call hepatic gluconeogenesis, like metformin. And one of the key side effects of metformin as a drug is a condition called lactic acidosis. That's why one of the contraindications for using drugs like metformin is if we have severe renal impairment, or if we have disorders of fluid balance, for example in patients with heart failure, specifically New York Heart Association classification 4, 5, and some sources even talk of 3. So those are the drugs like metformin. Then number 3, we have what we call sulfonyl ureas. Now this is another class of drugs, and one of the examples that we have here is a drug called glibenclamide or glibuzide. And these ones specifically work to increase the secretion of insulin, because one of the defects in diabetes mellitus is a deficiency or decrease in insulin production. And specifically how these drugs do that is by inhibiting or closing what we call the ATP dependent potassium channels. If we look at the beta cell that produces insulin, there are a number of receptors in the surface of that cell, including potassium channels that have a ligand ATP that binds to them. So when these potassium channels are closed, we are going to have depolarization of the cell membrane of the beta cell, and when we have depolarization, we are going to activate yet another receptor or another channel, what we call the calcium voltage gated channels. And so we have an influx of calcium into the beta cell, and with influx of calcium we'll have a concomitant docking of the insulin containing vesicles with the cell membrane and release of insulin by a process called exocytosis. So that is how sulfonylureas like glibenclamide work. And one of their side effects is hypoglycemia. So if we have a patient that is particularly at risk of hypoglycemia, we have to be careful with our use of sulfonylureas. Number 4 is the SGLT2 inhibitors. And an example here of such drugs is dapagliflozin, empagliflozin. Now these specifically work in the kidney to reduce the renal reabsorption of glucose. So a lot of the glucose is lost in the urine, and actually that explains one of their side effects, which is a patient suffering a lot of fungal infections, urinary fungal infections, because we have a lot of glucose being shunted out in the urine. The other benefit of these drugs is that in a patient with cardiovascular disease or at risk of cardiovascular disease, these drugs have a benefit to that patient. Then the other is the thiazolidinediones, also called the glitazones. Now these drugs specifically help to improve on the sensitivity of the peripheral tissues, including muscles, to insulin. And how do they do that? They upregulate or increase on the number of receptors, specifically GLUT4 receptors in the muscle cells. And they do that via PPAR gamma mediated action. So through this intermediate, those drugs are able to increase on the GLUT4 receptors, and so our insulin produced by the body has a higher chance of exerting an effect. An example of such drugs is pioglitazone. Then number 6 is the meglitinides, or what we call the glinides. And these drugs also help to increase on the secretion of insulin. They work in a similar mechanism like the sulfonylureas via a sulfonylurea receptor, which is located on the ATP dependent potassium channels in the beta cells. Moving on to our incretin modulators. Remember, in the ominous octet, one of the key defects is a decreased incretin effect, and so these drugs specifically target that component of the ominous octet. So dipeptidyl phosphate, dipeptidyl peptidase rather, is an enzyme that breaks down these incretin hormones. Incretin hormones, like we said, are hormones produced by the gastrointestinal tract, but that do many other functions, including stimulating the beta cells to release insulin. So this particular substance, dipeptidyl peptidase 4, breaks down those incretin hormones. And so when we use dipeptidyl peptidase 4 inhibitors, which are also called the gliptins, we are able to reduce the breakdown of the incretins, and so the incretins are able to linger longer and therefore exert the effects of stimulating insulin secretion by the beta cells. So an example of such drugs is a drug called saxagliptin. And then the last one here, glucagon-like peptide 1 receptor agonists. Now drugs like these ones increase on the response of the beta cells to circulating glucose. So like the name suggests, these ones are able to, mimic the effects of glucagon-like peptide 1 on its receptors on the beta cells, and even in other areas, because even in the central nervous system we have glucagon-like peptide 1 receptors that are involved in the control of appetite. So these are some of the drugs. We also have drugs that have a benefit of causing weight loss. And so if you want to achieve weight loss in your patient as concomitant or as a simultaneous effect, then you could also take advantage of drugs like those. And some of the examples of drugs that can cause weight loss, we have SGLT2 inhibitors, Even GLP-1 receptor agonists can cause weight loss, and so they're able to help you, kill two birds with one stone. Apart from the oral hypoglycemics, we also have other drugs that are used in patients with diabetes, for example, patients with comorbidities, or other risk factors that need to be mitigated. For example, antihypertensive drugs, that is the angiotensin converting enzyme inhibitors, angiotensin receptor blockers, then statins or lipid lowering drugs, then also aspirin, an antiplatelet that specifically low dose aspirin, except in patients where you pinpoint high risk of recurrence. Then also fibrates. So it's a wide spectrum of drugs, but our takeaway from this is the main drugs, or what you call oral hypoglycemics, are these. And these drugs are given in a number of regimens. It's what we call monotherapy, where one drug is used, and usually the first line is the bigonide metformin. However, if we're not achieving our targets, our HbA1c targets, we can add another drug, what we call add-on therapy. Or in some cases, we can even start the patient off with 2 drugs, and sometimes even we will add on until we get to 3 drugs. Though some guidelines say if the patient is not responding, or if we're not achieving our glycemic targets with 2 drugs, we can now go back to insulin, to basal insulin. Thank you. I hope you picked something from this video.